Hey, welcome everyone. So we'll get started now. Welcome everyone to our fifth session in VISCO 2022. My name's Cody. I'm one of the course co-directors for this year's course and an ophthalmology resident at the University of Ottawa. And so I just want to remind everyone about our schedule for the course. We're now in our fifth session on glaucoma and cataract with Dr. Kherani. And just a reminder that we have one session left in the course that's going to be on August 2nd or August 7th, sorry. We're taking a week off next week because of a long weekend here in Canada. And our final session will be on refractive surgery and uveitis. And so just a reminder for those who haven't attended our previous sessions here, there are some opportunities for you all to win prizes during the session today. So we'll be using an interactive platform called Kahoot. And you'll have the opportunity through this platform to answer some questions during the presentation. And for those who place in the top 10 of all participants, you'll be entered into a draw to win one of two $25 gift cards. So hopefully a nice incentive to answer some questions during the session today and try to apply your knowledge. And so just wanted to address some frequently asked questions up front. You can ask your questions during the session one of two ways. You can type them in the public Zoom chat box directly, or you can DM our moderator, Mohammed, as well privately. And Mohammed will be facilitating the questions during the presentation today. And also, we get a lot of questions about whether slides or recordings will be posted, if allowed by our presenter, which all of them have said yes so far. All the materials for the course will be posted at the end of the course sometime in August. And before I get to introducing our presenter, I just wanted to acknowledge the University of Ottawa Department of Ophthalmology for sponsoring this year's course. One more thing I wanted to plug before we get started today. I know many of our attendees at the course are from medical schools and medical programs outside of Canada. And so COSIG is actually recruiting for an international rep. So we're looking for someone who is going to or went to an international medical school and is planning to apply to the Canadian residency match. So we encourage interested applicants to apply. And it's a great way to try to engage with some of our Canadian programs here. And so without further ado, it's my pleasure to introduce our speaker for today. Dr. Irfan Kherani is an assistant professor at the University of Toronto Department of Ophthalmology and is a cataract, glaucoma, and advanced anterior segment surgeon at the University Health Network in Toronto. He completed residency training at the University of Ottawa with fellowships afterwards in glaucoma and advanced anterior segment surgery at U of T with Ike Ahmed and vision rehabilitation at UBC with Dr. Mary Lou Jackson. Dr. Kherani has held a number of leadership roles within medical education and has many contributions to the peer-reviewed literature in glaucoma. And so it's a real pleasure for us to be able to welcome here today to give you all this presentation. And so without further ado, I'll stop sharing my slides here and let Dr. Kherani take it away.
Oh, all right. Thank you so much for that warm introduction, Cody. I really appreciate it. So I will go ahead and kind of, just as Cody had mentioned, the team here is using Kahoot. So I think I've posted the information there for the game pin. So Cody, it's okay. Like, will that be posted in the chat and I can continue on from here? Okay, awesome. Does it look like? Oh, someone said, hey, has joined. There we get going. Oh, right. So thank you everyone for welcoming me here. As Cody mentioned, with that very, very warm welcome. My name is Irfan. I'm one of the glaucoma specialists here in Toronto at the University Health Network. And it's honestly my pleasure and my honor to introduce a lot of you to glaucoma. It's kind of a field that a lot of people don't really understand. They've heard the terms before, but really have a limited understanding of what it is because it is kind of complicated. And to be honest, we don't really know exactly what glaucoma is, but we do know a few things about how to treat it and how to prevent its progression. So thank you very much for the invitation to come and join the group here for today. And as Cody mentioned, please I encourage you to ask questions. I probably won't monitor that chat directly here, but Mohammed will kind of help us out after every subsection, and I'm more than happy to answer some questions. In the presentation, I've also included a few references to different resources that I used while I was in medical school and into my residency for those who are interested in learning about ophthalmology at large, but also in glaucoma in particular. So we'll chat a bit about those different resources as they come up as pictures. Full disclosure, a lot of the pictures that I take, I don't have full ownership for, but they are available in the public domain. So when we post that, we'll just make that note for the information for CO's sake. All right, so I wanted to start off with a bit of a background on why we use the term glaucoma. It's not a particularly common term. It's not a kind of a basic on the Latin form, but it's actually its origins actually come from a Latinized version of the Greek term glaucos, meaning shimmering or shimmering light. So up until the 1640s, we really didn't know the difference between glaucoma and cataract. And so they really were, in many cases, considered to be the same thing because they often presented with a whitening or a shimmering of the eyes in the central part of the pupil. And so for that term, it was termed glaucos or shimmering, which in time developed into the term glaucoma. And again, we'll chat a bit about what it means and why we use that term in the different forms. But that kind of gives you a sense that for essentially most of eternity, glaucoma and cataract were really considered the same thing. However, we now know that they are very, very different pathologies, often related, but very different pathologies. To start off, I want to kind of make acknowledgements to kind of three major resources that I really would encourage all of you who are learning a bit more about ophthalmology to make good use of. And I'm sure they've probably been referenced at previous presentations with previous presenters, but these were really the major resources that I used as I was learning a bit more about ophthalmology in the early parts of my career. So the first one is the Optibook that Tim Root wrote. It's published online. You can also get the hardcover copy, and you can get that you can order that in. Tim Root has also published a bunch of different really, really amazing videos for kind of people who are just getting into ophthalmology and want to learn a bit more about the field at large. I particularly like the clinical examination section. So I'm not sure if Mike referenced that during his first session, but the Optibook is a really, really good resource for medical students and for those that are starting in ophthalmology. Second thing is the basic ophthalmology book that was published by the American Academy of Ophthalmology, written by Cynthia Bradford. It is, again, a very, very basic book. And so it allows you to kind of get that initial terminology and the lingo that we often use in ophthalmology, which often comes across like a different language because we have a lot of acronyms and different references that can be quite challenging to work through. So the Cynthia Bradford book is fantastic. And for a lot of the medical students that come to work with me, I do really encourage them, once they've kind of worked through Optibook, that kind of next level is basic ophthalmology. Third thing I wanted to mention was iWiki, which was taken over by the American Academy of Ophthalmology. It's online and it is semi-peer reviewed in the sense that it's written by a bunch of different authors and they submit different articles, and then there are some kind of peer-reviewed natures to it. The iWiki, honestly, I can say I'm sure that Cody, you can maybe speak to this more in Ottawa now, but certainly when I was there, it was kind of our go-to resource when you're in clinic. So you see a weird case of retinitis pigmentosa and you can't remember what it is, you can't remember the different associations, you literally search iWiki retinitis pigmentosa and a great article on it will pop up. So the iWiki is a really, really good resource. It's also a good opportunity to get involved in ophthalmic literature if you don't have many opportunities. The iWiki group runs a series of different contests. Best submission every year. You have the opportunity to review older submissions. You can work with different people that are in ophthalmology to date. So for example, the primary open angle glaucoma section, for example, was last updated by Arsham Shabani, who's one of the fellows that was ahead of me. It's a great opportunity to really kind of get involved in literature, but kind of translational literature and good references on a day-to-day basis in ophthalmology. So with that, I did want to pay reference to these three because they did serve as kind of a good base for me when I was first starting, but also I used it as I was kind of coming together with this kind of basic intro for glaucoma. Next thing I want to talk about is acknowledging the mentors that you work with, and I'm really happy to see that this year's VISCO was hosted by the University of Ottawa. I can kind of pretty definitively say that Dr. Miller, who is a glaucoma specialist at the University of Ottawa, is probably the reason I'm in glaucoma today. And so as all of you work forward, for all of us that give kind of presentations and introduction sessions to different parts of ophthalmology, I encourage you that as you join the fields in the future, which I'm sure you will, that you also take on that responsibility and that opportunity to give back and act as mentors for future physicians in ophthalmology, for physicians and surgeons. So for that, I specifically shout out to Dr. Miller, but also really for all of you that will be joining our field, please take on this responsibility as you move forward and give back to the field and help kind of ignite that interest in ophthalmology amongst the future of our field. Okay, so interest in terms of kind of our structure of how we're going to approach things. As I mentioned, I am going to show you a few different kind of resources. So the first one I'm going to reference here is called the Review of Ophthalmology, written by Trattler, Kaiser, and Friedman, initially written by Friedman. For many of us that worked through our residencies, this was kind of the resource that you came back to on a day-to-day basis because it's only about 150 or 200 pages. And it was a kind of good summary for a lot of ophthalmology. So that was our first one here. But in terms of our overview, what we'll talk about today, I'm first going to go through the definition of glaucoma. From there, we'll talk a bit about how we complete a clinical history in glaucoma, followed by a clinical examination. And finally, what I think is probably my second most favorite part about discussing glaucoma, which are the investigations that we use. And finally, as a glaucoma surgeon, honestly, the treatments are changing very, very rapidly right now. We have a lot of cool new opportunities for how we can manage this progressive disease. So on this page, I am showing you a picture of the BCSC Basic Clinical Science course book, specifically on glaucoma. So for Cody and those that are residents, this will probably be your primary resource. And luckily, I can actually say over the last year, they've changed and updated it to include, along with a lot of the newer surgeries that we're doing with minimally invasive glaucoma surgery that really wasn't part of the curriculum and program in the past. So for those that want to get some more information, more into the resident level, the American Academy of Ophthalmology manuals in glaucoma are fantastic. So let's get going. So first, we'll chat a bit about the definition of glaucoma. And again, another resource for those interested in learning a bit more. Before I really started my electives in ophthalmology as a second or third year resident, the Toronto Notes summary on ophthalmology is actually fantastic. It really looks through, I mean, there's this section on glaucoma in particular, but also on kind of retinal diseases and the biggest ones, including diabetic retinopathy, as well as age-related macular degeneration. So the Toronto Notes section published by the University of Toronto students, and specifically the ophthalmology section, is a fantastic resource. And for those of you that are moving towards your licensing exams in medical school, the Toronto Notes at Large is a really, really good resource. And they now have kind of a clinical compendium that's in addition to it for those that are not necessarily studying for the American exams, sorry, for the Canadian exams, but for the international exams at large. But with that, let's chat a bit about the definition of glaucoma. So I'm going to go through this slide pretty slowly because this is often where people find things to be most challenging in the world of glaucoma. And that is, and we'll go through this slowly again, is that glaucoma is a group of conditions. So it's not just one, it's a group of conditions that are characterized by progressive optic neuropathy and characteristic optic nerve head changes and visual field defects. So if you could imagine, for anyone trying to study and research glaucoma, that's like the most difficult definition to use, because there is nothing that defines an inclusion with glaucoma or an exclusion with glaucoma, but it's a series of progressive changes to the cable that connects the eye to the brain or the optic nerve, cranial nerve 2, as well as characteristic changes that we appreciate on the optic nerve, as well as visual field defects. Now, later on in this presentation, we're going to talk specifically about those optic nerve head changes and the visual field defects, but this is how we define glaucoma. Now, as many of you are probably thinking right now, you'll notice there's one big factor in glaucoma that we often talk about that is not included in this definition. So my first question I'll ask the group here is, glaucoma is caused by increased eye pressure. Whenever we talk about glaucoma, it's kind of synonymous with increased intraocular pressure. In fact, if you go to the definition of glaucoma in Webster's dictionary, it references intraocular pressure. However, my question here is glaucoma caused by increased eye pressure? So we'll open that up to the animation here. So once again, glaucoma is caused by increased intraocular pressure. So that's true, false, or maybe. So we'll let that count down from 5 to 1. And so we have some people saying true, we have some people saying false, and we have some people saying maybe. And I probably did the terrible thing, but all three are correct. we can probably make the argument that glaucoma is very much associated with intraocular pressure, but not all patients with high intraocular pressure have glaucoma, and not all patients with normal pressure are free from glaucoma. And so we think that there's maybe some component that has a causal relationship, but at this point in time, when we define glaucoma in its truest sense, we do not put intraocular pressure actually in the definition of glaucoma. It's just an association. So we'll talk a bit more about that as well. So just to confirm again, glaucoma is a group of conditions that is a progressive optic neuropathy. So it's damage to the optic nerve that progresses with time and is associated or characterized by optic nerve head changes and visual field defects. And we'll talk about what those are in particular shortly. Awesome. GlocDoc seems to be doing really well, as well as a bunch of other people. All right, so let's write that down, kind of make that a bit more practical. So glaucoma is a disease of the optic nerve. We don't really know exactly why or how it occurs. So as I mentioned, we think that there's increased pressure. So a lot of the diagrams that you'll see will say there's increased intraocular pressure that causes damage of the optic nerve. That's probably true, potentially, but we don't know for sure. So there's some component of some sort of maybe mechanical effect of pressure on the optic nerve, plus or minus some vascular changes, because there are some hemorrhages and bleeding associated with glaucoma in certain presentations, as well as maybe some other biochemical conditions that are associated with glaucoma. So we have certain types of glaucoma, for example, normal tension glaucoma, which has normal pressures, that's often associated with vasospastic disorders, things like migraines and Raynaud's phenomena. So the short answer is we don't really know why or how it occurs. And that's often very challenging as a physician, kind of treats glaucoma all day long, that people often ask, why do I have this? What happened? And my only answer I can give them is it's in your genetics. We don't totally know why it happens, but it's happened and now we just need to treat it. We talked a bit about intraocular pressure or eye pressure, and glaucoma is very much associated with elevated or increased intraocular pressure. And what we have found and what every study has shown is that decreasing intraocular pressure reduces progression. How much reduction of the intraocular pressure do we need to establish reduced progression of the glaucoma? That's probably a billion-dollar question, and I encourage all of you to find the answer to that, because what our studies have shown us is that depending on the type of disease, the type of glaucoma you have, the severity of the glaucoma you have, the effect of decreased intraocular pressure on progression, we know is an effect, we just don't know how much is needed. So let's talk a bit about the production of aqueous humor or fluid inside the eye. So we think often of the eye as kind of a balloon. So in order for the eyeball to be well firm and kind of project light onto the retina and allow transmission of that information to the brain, we need to have a firm eye. And in order to have that firm eye, fluid must be produced and fluid must be released so that the pressures don't go too up, but they also don't go too low. So we'll start kind of at the bottom where you'll see there's aqueous humor that's produced. And Cody, is my cursor showing on the front there? I don't know. Okay, great. So we'll start here where the aqueous is produced in the ciliary body, which is right behind the iris, which is the colored part of the eye. So once again, the aqueous produced in the ciliary body, which is right beside the lens. It travels, once it's produced here, in front of the lens and behind the iris, through the pupil. And once it goes around the pupil, it drains into this area right here in between the cornea and the iris. And this is called, by definition, the corneo-irido angle, or the iridocornial angle, or what we often refer to as just the angle. So once again, 360 degrees around the eyeball, fluid is produced in the ciliary body, it travels in front of the lens, around the iris, and drains in this angle. Once it goes into the angle, it drains out into the lymphatics, and there's many different ways that it goes back and gets recirculated into the body. But the important part is there's a balance between the production of aqueous that's produced in produced in the ciliary body that travels in front of the iris and drains into the angle. Now, in glaucoma, we talk about two subtypes. There are two major types of glaucoma that we really need to keep into account. The first type is called open angle glaucoma. It means that fluid is produced in the ciliary body, it travels in front of the lens and above the iris and drains into the angle, or the trabecular meshwork, which is what kind of acts as the sieve or that angle of where the fluid is drained. What we postulate and what we think is that there's some mechanism that's inhibiting the drainage of fluid in that trabecular meshwork that causes the pressure to rise and in turn causes glaucoma. And that's open angle glaucoma, meaning that fluid gets to the angle, but there is some problem with the angle itself that inhibits the fluid from being drained. Next, we have angle closure glaucoma. And that's where fluid is produced in the ciliary body. It attempts to travel into the pupil, and when it travels through the pupil in front of the iris is positioned in such a way where that angle is not very easily accessible. And thus, fluid can't actually reach the drainage channel. So we don't think it's a problem of the trabecular meshwork, like is in the case of the open angle type, but really is a problem of the iris because fluid can't get to the angle itself. So that's how we differentiate the two major types of glaucoma: open angle glaucoma and closed angle glaucoma. So we'll go to our next question here, which is, what is the most common type? Let's go back to next year. So what is the most common type of glaucoma? Our options are either first, primary open angle glaucoma, which means it's that open angle type and there's really no known specific underlying cause. Secondary open angle glaucoma, which is where that angle is open. However, there is some sense of that there is some underlying mechanism that's driving that open angle phenomenon. Third, primary angle closure, and finally, fourth, secondary angle closure. And we'll talk a bit about those two as well. So I think the overwhelming majority of people kind of got it here, which is that primary open angle glaucoma is by far the most common type of glaucoma that we treat. Awesome job, everyone. All right, so let's go back to the definition of glaucoma. And now specifically, we'll talk a bit about the open angle component. So as I mentioned, in open angle glaucoma, there's a blocked aqueous drainage. And so fluid is getting to the angle. However, there's some problem when it gets to the angle that doesn't let the fluid go through all the way to the trabecular meshwork. It's most common and it affects about 80% of patients with glaucoma at large. So the overwhelming majority of patients with glaucoma have primary open angle glaucoma. There are some secondary types, meaning that there are some kind of slightly abnormal or anormal eyes that are associated with the same increased pressure with open angles. And one picture I've shown you here is called pseudo-exfoliation. It's kind of like if you think you have some dandruff built up inside your eye, that dandruff can block the drainage channels. And what we postulate is that that blocking of the drainage channels is what causes the increased pressure in this secondary type of glaucoma. So the pseudo-exfoliation is kind of like dandruff, and pigmentary glaucoma is kind of like the release of pigment off of the iris that also blocks the drainage system of the trabecular meshwork. So these are the primary and secondary types of open angle glaucoma. All right, let's chat a bit about closed angle glaucoma or angle closure. In this option, as I had mentioned, the aqueous is produced in the ciliary body, but it cannot reach the angles. And that's because the angles it cannot reach the trabecular meshwork because the angles are closed. So we have the primary disorder, which is called primary angle closure glaucoma, and we subdivide it into what's called acute angle closure glaucoma and chronic angle closure glaucoma. And we'll talk a bit about that in the next slide, as well as some other secondary forms. And a picture I've shown here is called neovascular glaucoma, where secondary to kind of some ischemic events in the eye produces new vessels, and those vessels kind of grow around the angle and they actually zip it up. And so no fluid gets access to the angle and no fluid is able to be drained. So we'll go on to our next question, which is, and this is specifically about acute angle closure glaucoma that we'll talk a bit more about in a second here. And that is, which of the following is not associated with acute angle closure glaucoma? So we'll go to that quiz here. So which of the following is not associated with acute angle closure glaucoma? And that's A, decreased visual acuity, B, nausea and vomiting, C, pain, or D, curtain-like visual field defects. So give it a few seconds for everyone to kind of put in their answers here. Awesome. So in this case, the answer is curtain-like visual field defects. So patients with acute angle closure glaucoma, which we'll talk a bit about now, often present with decreased visual acuity, nausea and vomiting, and pain. However, curtain-like visual field defects are more likely to be associated with retinal pathology and specifically retinal detachments. So let's talk a bit about acute angle closure glaucoma. So this is a picture here on the right-hand side. You'll see the patient's left eye, which is our right-hand side. This patient has acute angle closure glaucoma. And what happens in acute angle closure glaucoma is that while the patient had probably kind of intermittent opening and closing of their angles, so the fluid was still largely being able to be drained in the eye, there was a moment all of a sudden where the pupil got dilated, and following that, the complete angle completely closed. And all of a sudden, the pressure jumped from what was probably in the likely normal range to a very, very high pressure, 50, 60, 70 millimeters of mercury, which if you think about the pressures being kind of between 12 and 20, that's very, very high. And when that happens and the pressure spikes, often that's associated with redness and decreased vision, a fixed mid-dilated pupil like we see here on the left hand, on the patient's left eye on our right-hand side, redness, decreased vision, as well as a significant amount of pain and nausea and vomiting from that increased pressure in the eye. So when you're on your emergency rotations or other kind of general medicine rotations in a patient, they will often be referenced to that scary thing called acute angle closure glaucoma. And that's exactly what we have right here, what we're talking about. It's that presentation where all of a sudden the angle's closed and the pressures spiked to 60 or 70 millimeters of mercury. All right, so with that, now that we finished kind of the first section just on the background and definitions of glaucoma, I might ask Mohammed, do we have any kind of questions there?
No questions so far.
Okay, awesome. So why don't we head on to that second section here on the clinical history. All right, so let's go to our first question of this section, which is most people with glaucoma present with A, symptomatic decreased vision, B, pain from intraocular pressure, or C, no symptoms at all. All right. All right, great. That's absolutely the case. So the overwhelming majority of patients that come in with glaucoma do not present with symptomatic decreased vision or pain from elevated intraocular pressure. Typically, they have no symptoms, and it's found on a screening examination, either with their optometrist or their general ophthalmologist. All right, awesome job, you guys. So let's talk a bit about our clinical history and the types of things that we ask about when we assess a patient with glaucoma. Glaucoma is very much associated with increased age. So as you get older, your risk of glaucoma increases. It's more commonly associated with females rather than males. And specifically, there are some ethnic backgrounds that are more likely to be associated with glaucoma. We'll talk a bit about that on the next slide. And finally, any family history of glaucoma increases your risk of glaucoma. And this is specifically, we are talking about that 80% of the population, that 80% of glaucoma patients that have primary open angle glaucoma. So in the world of glaucoma, we have a number of major studies that have really shown us kind of the major amounts of information in our field. And I'm sure the retina team kind of spoke a bit about the retina studies, but in glaucoma, we talk a lot about what's called the ocular hypertension treatment study. And that really helped us define the risks associated with elevated pressure and developing glaucoma. And out of that study came this risk stratification analysis, or the POAG, or primary open angle glaucoma risk calculator. To be honest, none of us actually use this, but it does help us to give a sense of, as your age increases, your risk increases. As your intraocular pressure increases, your risk increases. We'll talk a bit about central corneal thickness and vertical cup to disc ratios, as well as visual fields in the next few slides. All right, let's talk a bit about ethnic background and gender and race here. So as we mentioned here, if you compare the male African-Americans to the female African-Americans, the prevalence of glaucoma is significantly higher amongst male African-Americans, up to around 12% by age 80. So it's a very, very high amount and high percentage growth. Women, again, are closer to about 10%, and which are much more than our Caucasian male and women, who have much lower prevalence rates. So when we think about ethnic background, it is very important, and it's probably one of the areas in medicine where I'm very conscious of writing down in most of my charts what the racial background of my patients is, because it plays such a huge role in risk stratification of glaucoma. Specifically, we're talking about open angle in this situation, or primary open angle glaucoma. We talk about African-American patients, but in angle closure patients, we often talk about Asian patients, people coming either from South Asia or East Asia. And interestingly enough, the highest prevalence of angle closure glaucoma is actually in Canada, in our north, and specifically amongst the Inuit people that live in Nunavut and, of course, across Canada as well. So there is a very strong ethnic predilection for certain types of glaucoma that we should keep in mind. Clinical history should always include an assessment of previous eye history, either previous traumas or other diagnoses. So in our first picture here, we see what's called an Irido Dialysis. So that's where the iris has been pulled off one section of where it inserts, typically due to blunt trauma. And in the second picture we see a previous surgery, and specifically what's called a penetrating keratoplasty. So that's a corneal, full thickness corneal transplant. Both of these conditions, as is the case with any previous eye history and any previous eye surgery, patients are at increased risk of developing glaucoma. And again, to review, glaucoma occurs, we think, typically secondary to increased pressure, and that's when there's an imbalance between the production of fluid and the draining of fluid in the eye. As such, anything that disrupts that balance of production and drainage will typically and often be associated with increased risk of glaucoma in the future. I do want to make a special note that in every part of ophthalmology, there's different varying levels of the importance of recognizing previous general medical history. And in glaucoma, the biggest considerations are, number one, we have a lot of different treatments available, but those treatments are very dependent on the patient's other medical systemic conditions. So for example, we are going to talk about some of the medical treatments that are drops that use beta blockers, for example, that would not be really good options for patients with a history of asthma or COPD. Patients that have an inflammatory history or uveitis, for example, that you learn a bit more about at next week's sessions. We typically don't like to use prostaglandin analogs because they are pro-inflammatory medications. They're the exact opposite of Advil, for example. They cause inflammation. And finally, glaucoma, in its definition, does not include or it cannot be secondary to another brain or neurological condition. So there are a number of conditions that are often associated with a progressive optic neuropathy. That's a change and a degeneration of the nerve that connects the eye to the brain. That is not glaucoma. So one picture I've shown you here are kind of white matter changes that are typically associated with multiple sclerosis. So multiple sclerosis, meningiomas, gliomas, these are the type of conditions that we always want to make sure that we are not missing before we diagnose glaucoma. Because if we were to miss those certainly major neurologic tumors such as glioblastoma multiforme, those are life-threatening, and if not treated can cause obviously much bigger morbidity and mortality than missing a diagnosis of glaucoma. So that's kind of a whole world in of itself of how to differentiate glaucoma from other optic neuropathies, but it is important that you review that on the clinical history. All right, so with that, I will check in with Mohammed again to see if there's any other kind of questions about the clinical history.
No questions yet again.
Awesome. So next we'll talk a bit about clinical examination. And I have a picture here of one of my mentors, Dr. Alan Solmovic, who's one of the cornea specialists at the University Health Network where I work. And using the slit lamp is a super, super important part of ophthalmology. And I encourage all of you, as you learn more about the field, to really recognize that unlike a lot of other specialties, our clinical examination really dictates the diagnosis. Patients can't tell you or describe to you the exact features that would differentiate different causes of vision loss. And as a result, it's really up to the provider, the ophthalmologist, the residents, the fellows to deduce what the underlying cause of the vision change is. And for that, clinical skills are very, very important in ophthalmology. So let's talk about the clinical examination in glaucoma. So as is the case probably in all of your different presentations you've had so far, we always check the vision and the pupils for our patients in glaucoma. And what we term the best corrected visual acuity, so that's the vision that the patient can see at a distance of either 20 feet or 6 meters, with their best corrected glasses, we want to look to see what their central vision is. Now, typically, again, there are exceptions to this rule, but typically the central vision is not affected in glaucoma until very, very late in the game. There are, again, as I mentioned, exceptions, but in the overwhelming majority of patients, they're not affected until very advanced glaucomatous disease. And second, the relative afferent pupillary defect is a reflection of a difference in the function of the optic nerve when you compare the right side to the left side on the same patient. Glaucoma typically presents as symmetric or slightly symmetric disease in both sides, and as a result, you would not expect significant relative afferent pupillary defect in our patients with glaucoma, certainly early in the scenarios. If you have very, very asymmetric glaucoma, you can develop an RAPD, but again, that's only in very asymmetric disease, and RAPDs are typically not present. So if I have a patient that comes in with very mild glaucoma and RAPD is present, that certainly makes me think that I'm missing some other optic nerve or optic neuropathy secondary to another pathology. All right, the next thing, again, we'll spend probably a bit of time talking about intraocular pressure. So intraocular pressure is the amount of pressure that is exerted by the eyeball as you press against it. So the same way you would talk about pressurized balloons, we talk about pressurized eyes. The gold standard for measuring intraocular pressure is called the Goldmann Applination Tonometer, and that's what we have a picture here of on the left-hand side. And what you see when you're looking through that tonometer is on the right-hand side where you see these two, what we call Myers, and we line those Myers up because essentially by putting pressure of about 3.0 millimeters squared of pressure on the eyes, we line up these Myers, and that gives us a reflection of what the pressure on the eye is. That's called applination, where you're actually pushing against the eye, so that's applination. And there's a couple of different types, the gold standard that I referenced, which is the golden that we have a picture here. And we'll just go on to the next slide here, where you'll see a second type of applination, which is called the Tonal Pen, which I'm sure a lot of you have used or you've seen in emergency departments or kind of in general clinics, not necessarily ophthalmology clinics. And finally, a newer type of pressure assessments is called the eye care. So I've pictured here the IC200, which is called rebound tonometry. So in this picture here, that little device has a little kind of tongue that sits at the very end of it, and that tongue rebounds against pressing on the surface of the cornea, and it gives us an assessment of the pressure. Now, you'll probably notice here that I haven't named what's called pneumatic pressure assessments here, which is where you use a puff of air that blows up against the eye, and the response to that is measured by the machine, which typically is found in primary optometry clinics. We don't really use gas-bound or gas-based pressure assessments just because they're very, very inconsistent. And unfortunately, whenever I have a patient that's referred in with a high pressure off of that assessment, more often than not, I actually have normal pressures. So I haven't listed it here just because that really is not the gold standard. That really, if you want to diagnose and assess someone's pressure, do it properly. So it's either using a Goldmann, and if you don't have that available, either a tonal pen or the eye care. Let's talk a bit about intraocular pressure measurements at large. So I did really want to bring up this picture here because someone with a pressure of 22 or 25 or 30, that could be normal for them. And if that's the case, that's fine, they don't need treatment. However, what we've seen in this picture, as you can see here, is that in blue, when you have your pressure measurements that are largely between 10 and 22, that's pretty normal. However, as you get above that, the number of patients that have very high pressures that do not have glaucoma is very low, less than 0.01 of the density of when we compare all patients at large. When we compare that to glaucomatous patients, as I had mentioned, patients in the normal pressure ranges, so that's kind of that 0 to 20 mark, there are still patients that have glaucoma, and we call that normal tension glaucoma or low pressure glaucoma in the past. That risk of developing glaucoma obviously increases as we age as we go through the higher intraocular pressures. So once you get to kind of the 50 range, yeah, you pretty much have glaucoma. There is a significant amount of diurnal variation, and typically we find that pressures of the eye in the morning are highest, and they decrease throughout the day. And what we do know as well is that there is increased variation in that pressure in patients with underlying glaucoma. So whereas you would have maybe 3 or 4 millimeters of mercury differences between the morning and the evening in our normal patients. In patients with glaucoma, they can have differences of up to 10 or 15 millimeters of mercury. So more diurnal variation in patients with glaucoma. Now, this is really what I want to drill home about. We've talked a lot about how intraocular pressures are an important part of the assessment of glaucoma, but they are not glaucoma in its entirety. So that's not all patients with high pressures have glaucoma, and not all patients with normal pressures are free from glaucoma. It really is kind of a multimodal, multifaceted diagnosis. And so intraocular pressures are an important, but just one feature that we look at in glaucoma assessments. Next, we're going to talk a bit about central corneal thickness. Now, if you recall, I had mentioned that in applination tonometry, or specifically the Goldmann, you are pressing against the cornea and you're looking for the pressure back, as in the kind of Newton's third rule, that if there's an equal and opposite response of forces as you press on the eye, the amount that cornea can push back against you is often different based upon how thick the cornea is. So for example, if the cornea is very thin, so what we call at the very top here a central cornea thickness in microns of about 445, that's a very, very thin cornea. And the ability for that cornea to push back against you is much reduced. And so we think that patients with low central corneal thickness actually have higher pressures than we're reading off of our Goldmann assessments. Similarly, patients that have very thick cornea, so let's say 645 microns, we are overstating what their pressure readings are. So for them, this is one kind of correction table that people may reference. They've kind of since been disproven because there's so much variability in these correction tables, so none of us actually use them. But at one point in time, we would say that if you had a central corneal thickness of 645, your pressure reading is actually 7 points lower than what you're measuring. And if you have a central corneal thickness of 445, your pressure reading is actually 7 points higher than what you're reading. Now, as you can imagine, as I've just said, that we don't really use these correction tables anymore. And that's largely because they've really been invalidated, that things aren't just as clean as just saying that we have to correct for just the central corneal thickness. And I am going to talk a bit about what's called corneal hysteresis, mainly because it's kind of my major interest in research and what I can specifically assess in my diagnostic assessments of glaucoma. And that is corneal hysteresis, which is a biomechanical property of the cornea itself. That looks at how well the cornea can dampen. So for example, if you think of a balloon and you add more pressure, if you had a really thin balloon that had poor tissue and it expanded too fast, it might pop. And if you had a balloon that had very thick material, even if you had a lot of pressure, it may not pop at all. So that's just kind of a simple way of looking at what we call corneal hysteresis. And it's an assessment of how much the cornea can kind of bend back and forth based upon increased pressure. So with that, I won't be one of those guys that kind of goes into too much detail about his clinical interests, but my guess is in the future, corneal hysteresis will be even a bigger issue in how we assess glaucoma, more so than intraocular pressure or central corneal thickness. So finally, we're going to talk a bit about gonioscopy. And gonioscopy is using lenses to look at that iridocornial angle that we talked a bit about earlier. And this helps us deduce the type of glaucoma. So we do gonioscopy to determine if the angles are open or if the angles are closed. And here, another reference I wanted to kind of refer everyone to is something from the University of Iowa called gonioscopy.org. It's an absolutely fantastic resource for learning about gonioscopy and how to differentiate different presentations on gonioscopy. So to keep things simple, gonioscopy is what's used to help directly visualize that angle that's behind the cornea in front of the iris to determine if the angle is open or closed. All right, now probably what most of you have kind of heard about when we're thinking about glaucoma, and that's an assessment of the optic nerve. And the big feature here we'll talk about is what's called the increased vertical cup to disc ratio. On the left-hand side of this picture, we're seeing an arrow that identifies the cup of the nerve. And in my definition, that's probably about 0.3, maybe 0.4. And that's well within the normal range. That was on our left-hand side. On our right-hand side, we have a much larger vertical cup to disc ratio. And then my assessment, that's probably somewhere about 0.9, maybe 0.8 or 0.85. And that's within the pathologic zone. So this is actually the the image of the nerve that really was used to describe and characterize glaucoma when it first became known as an entity. So when we talked about the definition of glaucoma, we talked about characteristic optic nerve head change. This is the characteristic optic nerve head change that we typically associate with glaucoma, and that's the increased vertical cup to disc ratio. Now, you may notice that I'm specifically not saying horizontal cup to disc ratio. It is associated with glaucoma, but not nearly to the same specific extent on our statistical analysis as compared to vertical cup to disc ratio. Second thing, when we look at the optic nerve, we'll look at is what's called focal notching. And that's where we have areas where that nerve tissue that's in that ring, that's outside what we call that cup that we referenced before. So that's the areas that are right here around the tissue that is still very nice and healthy. And in this case, it's very, very thin. Part of it here where we can see it's ultra thin, that would be called what we consider something called a notch or a change in the optic nerve. If this was a patient that I saw that had this nerve on their right-hand side and this nerve on their left-hand side, that would be called what we would call asymmetric cupping of greater than 0.2. And that is, it also does increase your risk of developing, or sorry, an increased risk of having glaucoma. So while I did say before that glaucoma is more often than not relatively symmetric, if you have a significant asymmetry, that is a sign of glaucoma. Finally, and kind of in the last view, we talked a bit about changes. We talked that there was maybe some sort of heme or vascular base component to glaucoma. And that's certainly the case in glaucoma, where we see different hemorrhages that can come around here. And interestingly enough, for those that are Canadian here, the name and the term that we use for that hemorrhage that often presents itself around the optic nerve is called a Drance hemorrhage, after Stephen Drance, who was a glaucoma specialist at the University of British Columbia. Unfortunately, he actually just recently passed away about a year ago. And so that is the Drance hemorrhage that's often associated with glaucoma. Finally, we'll talk a bit about the increased visibility of the lamina cribrosa, which is kind of the scaffolding of the optic nerve itself. And unfortunately, we can't really visualize it here just with this overexposed picture, but that is another feature that we look on optic nerve assessments. So I know that's a lot of detail, but really what I want you to focus on is that increased vertical cup to disc ratio. That's kind of the biggest thing that we look at, especially when we start our glaucoma assessments. All right, so with that, I'll just check in again with Mohammed to see if there's any questions.
Yep, so we got a few this time around.
Okay, awesome.
So first question that I got messaged was just if you could quickly re-explain what you were talking about, asthma and inflammatory conditions and treatments for glaucoma. If you just go over that again real quick.
Yeah, for sure. So many of the treatments that we use for glaucoma can cause difficulty if a patient has underlying conditions. So the big example we give is asthma and chronic obstructive pulmonary disease, because the treatment that we use is beta blockers, which reduce the production of fluid inside the eye. But beta blockers are also the exact opposite of beta agonists that we use for the treatment of emergent asthma and COPD. So as you can imagine, you can almost impose or create an asthma attack or a COPD exacerbation by giving a patient beta blockers. So I typically don't use beta blockers in my patients that have underlying COPD or asthma. With regards to the inflammatory side of things, as we're all aware, medications like Advil or naproxen are anti-inflammatory medications, and they are and they're kind of anti-prostaglandins, because prostaglandins are inflammatory mediators. The medications that we use to reduce pressure in the eyes are actually prostaglandin analogs, or they increase the amount of prostaglandin in the eye. So those can be pro-inflammatory. Unlike Advil or naproxen that are anti-inflammatory, these medications are pro-inflammatory. So we typically try not to use them in patients that are at increased risk of having inflammation in the eye, or it's not usually a systemic thing because we are treating them typically topically, but something to keep in mind. All right, what was the next question?
And next question is, don't patients with advanced glaucoma have corneal edema that may increase their central corneal thickness? So with thicker corneal thickness, may that be directly proportional to severity of glaucoma?
Yeah, really good question. So that's kind of when you get to the end stage point where you have very, very high pressures, you can absolutely cause corneal edema. But that corneal edema is not secondary to increased tissue, but rather an inability for the cornea to release or get rid of the increased amount of fluid in the eye. So whereas technically your central corneal thickness is thicker, it's not thicker because there's increased corneal tissue. It's thicker because there's increased edema or swelling inside the cornea. So it's a perfect example of where the CCT increase actually is kind of directing us in the wrong direction, where we want to use something like the corneal hysteresis, which is a better assessment of the actual movability of the cornea itself. So really good question.
And that's all the questions for now.
Okay, awesome. So now we'll move on to our next, this is on to investigation. So maybe, why don't we take maybe about a 5-minute break or so right now, Cody? Because we'll just go into investigations and kind of treatments and surgery at the very end. How about we do that?
Yep, sounds good.
Okay, awesome. So why don't we plan to come back? Shall we just say right at 4 o'clock? Is that reasonable? Awesome. All right, shall we get started again, Cody?
Yep, sounds good.
Okay, awesome. So we're going to spend the kind of last section the last couple of sections about investigations and the management for glaucoma. Definitely kind of my more kind of big interest. So talked a bit more about resources. So I know when I was going through my initial electives in ophthalmology in my third and fourth year, the two big resources I used, one of them was this synopsis of clinical ophthalmology by Kansky and Bowling. So this was one really good resource. It's very, very full of pictures, which is super, super helpful as you're learning about ophthalmology. So that would be the first one. And then we'll talk a bit about the Wills Eye Manual that I'll come to at the end, which again, I'm sure a lot of you have seen before. However, for those of you that want a more kind of systematic approach to clinical ophthalmology and the assessments, Kansky's is fantastic. So there's a couple of different, few different versions of the Kansky's book. So there's the synopsis of clinical ophthalmology, which is kind of a pocket book that I used a lot. There's also this larger clinical ophthalmology book, and then the larger major resource that a lot of us used as we were kind of sitting for our final exams. So good kind of base to look at things. All right. So first thing we're going to look at in our investigations of ophthalmology is optical coherence tomography. And another resource I'd like to refer all of you to is something called OCT cases, which is a collection of cases that are based on OCTs that were initially created by the University of Toronto residents here, and now kind of it's expanded, and there's kind of involvement from a few different people and medical students and residents across the country. But there's a really good resource to learn a bit more about OCTs. If I'm not mistaken, I think Dr. Dana Albrecht did a session on OCTs for you guys earlier, and so I probably kind of went through the basics of things, but learning about OCTs is incredibly important in ophthalmology, as it really serves as a lot of our objective assessments moving forward. So kind of truth be told, as a glaucoma specialist, we talked a bit about vertical cup to disc ratios, and I have to admit that I actually don't record vertical cup to disc ratios on my charts anymore, because I really depend on OCT analysis for their objective assessments that guide my management plans moving forward. So just kind of in summary, OCTs are non-invasive diagnostics that utilize light waves to capture higher resolution cross-sectional images of different parts of the eye. So I'm not going to go into too much detail, but I encourage you to kind of look at Dr. Albrecht's presentations as well as OCT cases to learn a bit more about OCTs. But the important part, it gives us an objective structural or anatomical assessment of different layers of the eye. So the first usability of OCTs, moving kind of from anterior to posterior, is actually an assessment of that iridocornial angle. So we talked a lot about gonioscopy, which is still the gold standard. However, when I'm analyzing or assessing patients, to look for angle closure or open angles, really all of my patients undergo an anterior segment OCT, and we can see here on the right-hand side that this here, where I'm pointing to, is the iridocornial angle, and it's very open, at least 30 degrees here. However, we're looking on this left side, sorry, on the right side here, this angle is much narrower, and this kind of elevated bright part is actually the trabecular meshwork, and it's closed off. So this helps us really to kind of definitively deduce what would be considered open angle versus closed angle. And so for that, the anterior segment OCT is fantastic, and it's really only been on the market for the last 10 years, but it is a huge part of my practice. Next, which is the kind of mainstay of glaucoma treatment, is optical coherence tomography of assessments of the retinal nerve fiber layer. So I'm sure that when you had your initial sessions on retina with, can't remember, was it, who did the assessment on retina?
Adnan.
Oh, Adnan. Okay, so when Dr. Alami went through all those great retinal backgrounds, he certainly looked at OCT of the macula and the different layers of the retina. And so one of the layers is the retinal nerve fiber layer, and that's the connection points of the retinal nerve ganglion cell layers, ganglion cells, and how they connect to the optic nerve. And so in glaucoma, typically we look at, in this glaucomatous, the adjective glaucomatous nerve, we typically see loss in this superior pole and this inferior pole here. So you can see kind of in this superior pole of the optic nerve, it's red, and that inferior pole, it's red. Same thing on this side here and this side here. So these would be classic optic nerve damage secondary to glaucoma. Only difference in this patient here that I'm showing is that they have very, very large nerves. Most nerves are about 1.5 to 2.5 squared millimeters. This patient's nerves are about 3.5 millimeters and 2.8 millimeters. So a bit larger, but certainly this patient has glaucoma from an optic nerve assessment side of things. Similar to the anterior segment OCT, it's probably only within the last kind of maybe 10 years that we've started looking at macular assessments of glaucoma, and rather than the full macula that we look at when we're analyzing for diabetic macular edema or subretinal fluid in the case of age-related macular degeneration. In glaucoma, we're specifically looking at the ganglion cell layer, which is the layers above, a bit higher up here. I'm not going to go through the kind of subdivisions there, but in glaucoma, typically we get this kind of either the top part or the bottom part areas that are thin in glaucoma. However, the ganglion cell layer is much less specific to glaucoma than those specific RNFL findings, but they are an important part. So optical coherence tomography, very, very important part of ophthalmology. And specifically in the world of glaucoma, we use it to assess the anterior segment for open and closed anatomy, the retinal nerve fiber layer, and finally the ganglion cell layer. Now, we'll go to our next question here. So glaucoma, I'll just go to the next slide actually here. So to our quiz here, which is glaucomanous visual defects include either A, central visual field defects, B, peripheral visual field defects, or C, both of them. And I'll give you a few seconds to answer that. Awesome. So really interesting question. The overwhelming amount of visual field defects that we typically talk about in glaucoma are peripheral. So that's absolutely correct. However, a smaller portion, but still present, visual field defects include central visual field defects. So they really can be both. So kind of for that reason, I said all three answers, because you can have central, peripheral, it can be both, can be one or the other, can be neither. So really any of those. So let's talk a bit about assessing visual fields. Now, visual fields can be assessed either in a quantitative or specific fashion, where there's specific points at specific brightnesses that assess the peripheral visual field of a patient. And the gold standard for that kind of specific assessment that's quantitative is the Humphrey Visual Field Analyzer produced by Zeiss. And that's kind of really what the overwhelming majority of ophthalmologists use. However, there are different other ones, including the Octopus and different other companies that make visual field analyzers. But this is largely the mainstay kind of assessments that most of us use. They're broken up into three different types, either the 10-2 that assesses the central 10 degrees of vision with the two spots in the central vision, which is why there it's a two-part. A 24-2, which assesses the 24 degrees around a patient's vision. However, there's extra focus specifically on the nasal component, which is where glaucoma typically hits first. And finally, the third visual field, which is a 30-2, which is the central 30 degrees of vision. As you can imagine, these are what we use to assess our visual fields. However, you definitely, in a normal visual field, have more than 30 degrees. So for anyone that thinks that our visual fields assess all of our peripheral vision, that is absolutely untrue. Our visual fields, if we're using these machines, only assess a center component, specifically the central 10 degrees, the central 24 degrees, or the central 30 degrees. If we truly want a peripheral visual field assessment, we need to use other devices, including what's also called a Goldman perimeter, or what's kind of the more modern ones are the Octopus new perimeters. So let's talk a bit about the visual field printouts that you get. And really what I want us to focus on is the top kind of left-hand corner over here. When we see things that are, these are what we call our indices for reliability. So the fixation target means that the patient was looking in the center component, the center visual field, because we do want the patients to be looking in the center so that we can see their peripheral visual field, so that they're not actually looking at those peripheral points. What we do want to see is relatively low false positives and false negatives and fixation losses. So really anything that's greater than about 20 to 25%, I would kind of venture say that it's probably not the most reliable, but those are really the important parameters that we would look at before we would even look at what the patient's visual field is here. So what we're presenting here is actually a completely normal right visual field. So right because it says right at the very top, and also because this black spot right in the middle here is the visual field defect that we typically get by virtue of our optic nerve as it enters the eye. So this optic nerve blind spot is in the right-hand side, and so therefore this is the right eye. The various indices here, I'm not going to go into too much detail here, but the important part here is that I want you to recognize that there are reliability indices and that this spot here that we see is normal and is typically where the optic nerve inserts into the eye. So let's look at a few different visual field defects. And starting off on kind of visual field defect A is what's called a nasal step. And that is where on the nasal visual field, we lose some vision. And this is the classic first finding of patients with visual field defect secondary to glaucoma. So for that reason, we have more points in our nasal field when we do that 24-2, which is the classic glaucoma visual field. B is what's called a temporal wedge. It's actually relatively uncommon as the first presentation of a visual field defect, but it can be found. C, an established superior arcuate defect, or what we just called an arcuate defect. Again, typically is what a nasal step turns into. So the nasal step turns into a superior arcuate defect. And as you get more and more pronounced, you get up to kind of G, which is the tunnel vision defect that spares that temporal crescent. And finally, you kind of get end stage of complete visual field loss that involves the central vision. If you notice here, looking at kind of E and to some extent D, we do have relatively central visual field defects that can present with glaucoma. So if glaucoma hits certain parts of the optic nerve, you can get central visual field defects that do affect the central visual acuity. However, they are just much less common, more typically associated with our atypical types of glaucoma, like normal tension glaucoma. So this is really that kind of the cartoon version. And then now we're looking at really how they look like when you see the visual field. So this first kind of area here is our kind of more typical nasal step that's turned into an arcuate. Here we're seeing again more of that nasal step that's turning into an arcuate. We have a paracentral defect here. So things aren't quite as crystal clear as you would expect on that, as we saw in that first picture, but this is really how they present themselves. So you're looking for patterns. It's kind of a specific amount. Interestingly, in all these pictures I'm showing here, all of them have what's called a mean deviation. So there's only a loss of what we call 5 units or decibels, but they all have different locations for that visual field defect. So even though the number is all the same for all of these, the location for those visual field defects is obviously very, very different. So again, our more classic presentation is this nasal step that's turning into an arcuate. Here we have an inferior nasal step. Here we have a paracentral defect, another paracentral defect, a more kind of full-on thick superior arcuate defect here. With that, I will stop for a quick second just to see if Mohammed, if there are any questions.
Yeah, so we have 2 questions. So the first one is following up on the prostaglandin discussion. Would prostaglandin agonists be contraindicated in inflammatory glaucoma, or can they still be used?
So the short answer is inflammatory glaucoma. It really depends on what the mechanism driving that inflammatory glaucoma is. So if the patient had a previous, for example, I don't know, let's say herpes-associated glaucoma, which is one subtype of open-angle glaucoma, then yes, we really wouldn't use prostaglandins if we could get away with them. However, a recent review of a lot of the studies that argued to kind of limit our usage of prostaglandin analogs really have actually been disproven. So I'm a little bit more willing to use prostaglandin analogs in patients with inflammatory glaucoma, just because the risks are actually relatively low and the prostaglandins are very, very strong medications.
And the other question is, why exactly are thinner corneas more at risk for developing glaucoma?
Interesting. So I guess there's 2 answers to that question. The first answer is with thinner corneas, the ability for the cornea to kind of be pushed in is increased. So we think that if there is some mechanical underlying component to glaucoma, that ability for that mechanical change is probably more pronounced in patients with thin corneas. However, even when we take into account like that pressure difference or changing the pressure readings we have with differences in cornea, central corneal thickness was an independent risk. So even if we take into account changing our pressure readings, it's still an independent risk, which means that there is some sort of underlying kind of plasticity of the cornea that's causing some worsening of glaucoma that we don't actually understand. So it's a combination of an easier way to push the cornea in, which is changing our measurements for our glaucoma, our pressure readings, but also there's some underlying kind of nature to it that's also causing change. So it's a combination of both.
Yeah.
Awesome. So let's talk a bit about kind of the fun part of glaucoma. So for many, many decades, glaucoma was considered a really, really boring part of ophthalmology. And the reason for that is there was really, I mean, apart from major surgery, so for example, here we're looking at what's called a trabeculectomy. Apart from a trabeculectomy, there was really nothing else we could do surgically. And so really the mainstay of treatment was really drops. And often drops didn't lower the pressures enough. And so really these glaucoma specialists would basically watch their patients go blind with very little to do because the risks of surgery were so high and that the drops just weren't cutting it. Now we're kind of having a new renaissance in glaucoma over the last 5 to 7 years, where there is so many options for medical, laser, and surgical treatment. So I'm going to provide you just kind of a quick summary of some of the options that we have available to us for management of glaucoma, and I'll specify which ones are typically more for angle closure glaucoma and which ones are typically more for open angle glaucoma. All right, so again, looking at some more references. So the American Academy of Ophthalmology publishes what's called the preferred practice patterns. And these are kind of the guidelines that as ophthalmologists, we kind of adhere to for how we manage different major conditions, including open angle glaucoma and angle closure glaucoma. So the mainstay treatment for open angle glaucoma is pressure reduction. And how we do that is either decrease the amount of aqueous fluid that we're producing, or we increase the drainage of fluid that's already being produced in the eye. Because as I remember, if I had said that glaucoma and increased pressures are when there's an imbalance between the amount of fluid that's created and the amount of fluid that is drained. In order to, now we're looking at angle closure. So that second component, this is the preferred practice pattern for primary angle closure. In this case, our goal is not necessarily just to reduce the pressure, but rather to increase the access to the existing drainage system. And if we can increase the access to the drainage system, the hope is that the drainage is actually normal and that pressure should decrease. However, sometimes that's not enough. And so if we can't simply increase access and the pressures don't come down enough, then we start thinking about decreasing the production of fluid or increasing the drainage of fluid in other mechanisms. That's not the normal pathway. So first we'll talk a bit about drops. And as you start ophthalmology, you come to realize that drops are very, very difficult to remember and learn. And so I do want to give you the acronym ABC as in ABCs, P plus or minus a second P. That was kind of the way that I remembered it for myself. So A, alpha agonists, B, beta blockers, C, carbonic anhydrase inhibitors, and then we jump to P and P, which are prostaglandin analogs, and pilocarpine, which is a parasympathomimetic analog. So A, alpha agonists would be things like brimonidine or brimonidine. B, beta blockers, the most common one that we use now is timolol. We do have something called betaxolol as well. C, carbonic anhydrase inhibitors. These are things like dorzolamide or brinzolamide. For anyone who's done any mountain climbing up Kilimanjaro or Everest, you would have taken something called acetazolamide, which is a very similar medication, just in its oral form. Prostaglandin analogs we've talked a lot about here, but these are pro-inflammatory medications. And finally, pilocarpine, which is a parasympathomimetic medication that actually causes the pupil to constrict and allow more fluid access to the existing drainage channels. Now, A, B, and C, alpha agonists, beta blockers, and carbonic anhydrase inhibitors, they decrease the amount of fluid produced in the ciliary body largely, and prostaglandin analogs, the P, and pilocarpine, the P, increase the amount of fluid that's relieved, that is drained out of the eye, either through what's in the normal traditional pathway or through some other pathways that we won't go into too much detail about now. So again, there's ABC, which are decreasing the tap, and P, which increase the outflow of fluid out of the eye. So the mainstay for medical treatment, the overwhelming number of patients that have glaucoma never need surgery, never need kind of big lasers or small lasers, but they are treated primarily with drops. So that's A, B, C, P, and P. Move on to lasers. So for laser peripheral iridotomies, we had talked a bit about angle closure mechanisms. And we'll start off with this first picture here where that iris is riding up. And so because of that, even if fluid gets around, there's no access point to that angle. So sometimes what we do is we put a little hole through that iris, and instead, rather than the fluid getting trapped in underneath trying to get to the front of the iris, it actually can just go straight through the iris, and somehow that causes the physics of the situation causes that iris to sometimes flatten, and you get much easier access for that fluid to get into the eye. Some people ask the question, do we just do the one hole here? Do we need to do multiple holes all the way around? A bunch of studies did look into this, and really what they standard of care is really just to do one hole. And by doing that one hole in the iris, fluid is able to get through and push the iris back down, and the entire angles often will open up. It doesn't happen in all situations, but by virtue of making just that one hole, the entire iris typically flattens down, secondary to what we call a mechanism called a pupillary block. So the medications that we talked about here on the medical side of things can really treat primarily for primary open angle glaucoma, and the laser that we would use here is primarily for primary angle closure glaucoma. If the pressure doesn't come down sufficiently with this laser iridotomy, then we of course would go back to using those drops to help reduce the pressure as well. Second type of laser we're going to talk about here is, let me go to the next one. So resume. Okay, second one we're going to talk about is called laser selective trabeculoplasty, or SLT. And this is where we shine the laser directly into that angle. And while it looks as though we're creating little holes here, we're not really actually creating holes. We're creating a chemical change in the trabecular meshwork so that it more readily drains fluid. So in the past, we had something called argon laser trabeculoplasty that actually did just create holes in the drainage system of the eyes. With selective laser trabeculoplasty, we're just creating a chemical change that allows more fluid to be drained out of the eye. Now, many people ask the question, is SLT stronger than drops? Is it SLT less strong than drops? There's no clear answer to that. But usually when I kind of advise and counsel my patients, I say that SLT is roughly equivalent to about 1 drop. So if you think you need to be on 1 drop, you probably can get away without you having to start any drops just by doing SLT. And in my practice, SLT is actually my first line agent. So for my patients that have open angles that just need some pressure reduction, I use SLT first. And if SLT is not sufficient, I add on drops. So kind of dissimilar to how things were done in the past, but that's kind of the mainstay and standard of treatment now. Next, we'll move on to what's called cyclophotocoagulation. So cyclophotocoagulation is actually using laser to ablate the ciliary body. So if we review from the beginning, the ciliary body is where fluid is produced inside the eye. So if we ablate it, AKA kill off the cells that produce fluid, the pressure should decrease because we're turning off the tap by actually killing off the cells. And there's really 2 ways of doing cyclophotocoagulation, either externally or actually going internally and lasering directly on the ciliary body. We have the external version that I've showed here, where there's a traditional form where you use fairly high powers to ablate that ciliary body that in this case would be directly inside the eye here through the scleros. This is called transscleral cyclophotocoagulation. Or we have something that's called micropulse, which is similar to that transscleral, except it's a much reduced form and it's a lot safer than the high dose lasers that we use for transscleral cyclophotocoagulation. The second type here of cyclophotocoagulation, which is internal or endocyclophotocoagulation, this is probably one of my favorite kind of procedures I do because it's kind of like a video game where you have this kind of monitor and you have this probe that's actually inside the eye and you're looking at your monitor and you're ablating the ciliary body directly by looking at it. So super, super cool procedure. We shine and shoot light directly at the ciliary body and decrease the amount of fluid that's produced. So super, super fun. And it's a really, really good tool that I use typically in combination with cataract surgery. Next, we'll talk a bit about the kind of true incisional surgeries. And that the first one is actually cataract surgery. And this is a very, very large lens. Typically, we don't take cataracts out in their kind of as a single form like this here. But if we take the lenses out of the patient's eye by increasing the amount of space available, we actually increase the access to the drainage systems that are existing in the eye. So cataract surgery in of itself decreases pressure by 10 to 2 to 3 points, and it's definitely more pronounced in our angle closure patients. So on the top here, I have a picture of a patient that has angle closure where there's very little access to that drainage channel. We do cataract surgery, that iris falls completely back because we've taken out that big hefty lens inside the eye, and now there's much better access to the drainage channels. And the pressure typically, again, reduces, can be up to 10 or 15 points, depending on how high the pressures are before cataract surgery. So first, kind of the mainstay treatment for surgical side of things in glaucoma is actually just cataract surgery. Next, we'll talk a bit about improving the body's existing drainage system. So that's where, if you remember, we had the existing iridocornial angle where the trabecular meshwork is, which is the drainage channel for the eye. Now we have what's called minimally invasive glaucoma surgery, where we do treatments on that angle to help it drain a bit better. So first option is we can either remove the tissue of that angle here. So we see some pictures here of the iridocornial angle when we're in surgery, and we actually remove the tissue. That's called goniectomies, or removing tissues. And the mainstay treatment of that is what's called the Cahoop dual blade. It's a little blade here that allows us to actually remove the tissue. And that allows the fluid to be drained a bit more easily directly into the collector channels. Or we can just incise the drainage channels. And this is what's called a gonioscopy assisted transluminal trabeculotomy. Don't worry, you don't gotta remember that. But essentially what we do is we take a suture and we put a suture inside the drainage systems and we pull it open. So we're basically cutting through the existing drainage system that the eyes have so as to help fluid drain out of the eye. So these two are called, again, minimally invasive glaucoma surgery. And this is where we're treating the body's existing drainage channels. We're just helping it move a little bit better. This is very dissimilar to our traditional glaucoma surgeries, which are true filtering surgeries, where we're creating a whole new drainage system. So the body, we cannot depend on the body's drainage system. And so essentially we create a trap door around the eye and we allow fluid to come out of the eye. And this was the goal of mainstay treatment, which was called the trabeculectomy, where we make a hole in the sclera and we allow fluid to be drained out of the eye, and in doing so, decrease the pressure of the eye. This is what's called a trabeculectomy bleb. So fluid, as you can see here, that is inside the eye is being drained outside the eye, just underneath the skin of the eye, aka the conjunctiva. So this bleb here is an illustration of fluid that's coming outside of the eye and not draining in the eye's normal drainage system. And trabeculectomies can get your pressures very, very low. I have some patients that, start off with pressures in the 30s, 40s, and after trabeculectomy can be stabilized at a pressure of 6 or 7. So very, very, very good procedures. However, they are very relatively risky in the sense that there's a lot of variation in how trabeculectomies can be done and the kind of final output of the pressures that you get. What I prefer to do are creating a whole new drainage system, but using implants. So those can be either the big one that are on the markets right now, or what's called the Zen gel stent or the PreserFlow micro stent. And that's where we inject an actual implant that connects inside the eye to outside the eye, underneath the conjunctiva or the skin. So just like the trabeculectomy, fluid is being drained into that space. However, it's with the use of an implant, not with the use of the body's own tissue. So it's a lot more predictable, a little bit more challenging, but a lot more predictable, and you get some really good pressure resonance. And so again, these are the kind of real glaucoma surgeries. These are the ones where we're creating a whole new drainage system for the eye to bring down pressures. These are just some examples of the blebs that we can create. So this is another cross section of the front of the eye here and here. So this is the iris, and this is the cornea. And what we can see is this kind of fluid that's tracking through this implant that's coming through right here. So just to give you a sense of how the implant, you can see just the implant right there. It's very, very small, about 60 microns in diameter. So very small, but it allows a controlled amount of fluid to drain out of the eye so that we can have a controlled pressure. Finally, we'll talk a bit about kind of the largest implants that we do, which are called the tube shunts. And that's where we have this big plate that we suture onto the back of the eye. And that tube, that plate connects right directly inside the eye and drains fluid all the way back here. And those are primarily the almond glaucoma valve or the bare-baked glaucoma device. Again, bigger tube shunts, larger amounts of pressure reduction, but same purpose of creating a whole new drainage system. So with that, we'll go through a bit of a summary. Again, as our final resource I'm going to talk to you about is something called Ophthalmology Glaucoma. So you'll probably have often heard people referencing the Blue Journal or the Ophthalmology Journal. There's a new kind of sub-journal called Glaucoma, one called Ophthalmology Retina, and one called Ophthalmology Basic Science. And Ophthalmology Glaucoma is a really, really good resource for getting to know kind of what's up and coming in the world of glaucoma from a research standpoint. So we'll talk a bit about the Will's Eye Manual. So I had referenced that there were kind of two big resources that I used while I was starting my ophthalmology career. The first was that Kansky's clinical reference guide, and the second one was this Will's Eye Manual. It's a really good summary of the different kind of subdivisions of glaucoma, of ophthalmology, and it allows you to get a good sense of kind of what's going on in the world of ophthalmology in these different sub-areas. We talked a bit about the definition of glaucoma, specifically how it's an optic neuropathy, damage to the nerve that connects the eye to the brain. often associated with increased pressure. However, that's not the strict definition of glaucoma, and it's broken up into two major subtypes, open and closed. The clinical history really is looking for risk factors for glaucoma, so things like ethnicity and family history, as well as kind of gender, and finally, treatment considerations if they have a history of asthma or history of inflammatory diseases or a history of any other surgeries or a previous eye history. The clinical examination is a super important part of our assessments, typically looking at the intraocular pressure, but now we look at the intraocular pressure with respect to the central corneal thickness and what I think is going to become the mainstay treatment of the mainstay assessments in the future, which is the corneal hysteresis. Fourth, we looked at investigations, specifically the OCT, as well as the visual field, which are the mainstays of how we diagnose and track and follow glaucoma. So often we make the diagnosis of glaucoma based upon the optical coherence tomography of the retinal nerve fiber layer. However, we follow glaucoma and we stage it based upon the visual field. And finally, treatment, whereas in the past we had a couple of drops and really just the trabeculectomy over the last couple of decades, we've now seen that explode into a world of multiple drops, multiple different types of lasers, and a huge variety of different types of surgical considerations in the world of glaucoma. So with that, I will say thank you so much for the opportunity to come speak to all of you. I will open up for questions for sure with Mohammed here. As I kind of had mentioned, I'm affiliated with the University of Toronto and we do a lot of research. So if anyone's interested in learning a bit more about our research program and getting involved with us, please feel free to reach out to us. I've put my email down here. If there's any guidance, any kind of encouragement I can provide to you, again, please feel free to reach out to me. And with that, I will just check in with Mohammed to see if there's any other questions.
Yep, so I got one question right here. Is there any long-term negative side effects of cyclophotocoagulation since there's no more aqueous humor fluid flowing normally through the eye?
Really good question. So one thing I should kind of specify and kind of clarify here is that when we use cyclophotocoagulation, the intention is not to completely ablate the ciliary body. If we were to completely ablate the ciliary body, the pressure would come down to zero and the eye would involute, and that would get what we would call something called phthisis, which is basically when the eye degenerates. And that's when you kind of see people that have small eyes. So when we do cyclophotocoagulation, we do want to be very, very careful how much power we are using to induce how much damage or ablation of the ciliary body. I typically quote my patients that there is roughly a 10% chance that we will use too much power and your eye will unfortunately suffer phthisis. So traditional cyclophotocoagulation, transscleral, high-powered cyclophotocoagulation is really reserved for kind of my end-stage glaucoma patients that have painful eyes. There are, again, those newer versions with reduced amounts of power that I would use kind of in our earlier presentations. But really good question. Awesome. With that, I will hand it back over to Cody.
Just one more question.
Oh, another question there? Yeah, for sure.
Yeah. Is it the case that IOP is temporarily increased after cataract surgery and then it goes lower than baseline long-term?
Ooh, good question. So what the pressure is in the eye immediately after cataract surgery really depends on how much the surgeon inflates the eye at the end of surgery. So I tend to hyperpressurize my eyes because I do a lot of glaucoma surgery. And if we have two pressures that are too low, you get some kind of resultant bleeding inside the eye. So my pressure readings right after surgery tend to be on the higher side. However, it's exactly kind of as you mentioned that the long-term stability and homeostatic levels that the pressures end up at typically tend to be in open angle patients about a couple of points lower, and in angle closure patients can be a significant difference, even 10, 12 millimeters of mercury.
Great, thanks.
Awesome, thanks, Mohammed. So with that, I will pass it over to Cody.
Thanks, Dr. Kherani. And I just want to thank you again for taking the time out of your busy schedule to prepare this really excellent presentation for us. I'm just going to share a closing slide here. And so, like we said at the start of the talk, we will be posting a recording of the session later on. So for any medical students who want to review Dr. Kherani's talk again and some of the clinical pearls that he shared before your electives, I'll be posting this by the end of the summer. And in the chat, we shared the two winners of our Kahoot draw. So hi, and I am competitive. You won a $25 gift card. So just take a screenshot of your Kahoot and send it to our email, and we'll get in touch with you for your prize. And we'd also really appreciate it if you can fill out our post-session survey. It just helps us get some feedback so that we can try to improve these sessions moving forward. And so with that, that's it for this week. I just want to thank Dr. Kherani again for his session today, and we'll see you